That doctor was so sweet and kind and smart, too. I like that in a man. He said the mole was nothing serious. I think he liked me, too. I mean, I could tell by the way he smiled at me, the way he touched me. You don't just touch somebody unless you like them. I wonder if I'll get to see him again.
One senior resident just wouldn't let me alone. She kept at me to have drinks with her after work. I said no as politely as I could. Do you know what she said? She said it was in my best interest to accept because she wrote my evaluation at the end of the rotation. She infuriated me, but I decided to go because I felt like I had no choice. Frankly, I was afraid she would put stuff in my file, and then what was I supposed to do? Besides, who would believe me if I said that a woman was sexually harassing a man?
There's a mole on the side of the patient's left breast that you might want to take a look at. Maybe it's nothing, but better safe than sorry.
Good morning, Ms. Long. Good morning, Ms. Long. I'm Dr. Winters. Dr. Johnson says you have a mole we need to look at. You've already looked at it and formed an opinion?
Oh, he's looked at it very closely. I'm actually quite concerned about it.
Please sit back.
I have looked at it. I'm pretty sure that it is benign. I've run through the ABCD criteria, and it has none of the red flags. But I'm not 100% sure.
Dr. Johnson, do me a favor. Please see if there are any other patients waiting for us. I'll be with you in a few minutes.
Sure, okay.
You can sit up now. Well, I believe Dr. Johnson was correct in his assessment. I, too, believe it's not cancer. I don't think there's any reason for concern. We'll monitor the mole to see if it changes. I don't think it will, though.
Thank you.
Good morning, Ms. Long. I'm Dr. Winters. Dr. Johnson says you have a mole we need to look at. You've already looked at it and formed an opinion?
Oh, he's looked at it very closely. I'm actually quite concerned about it.
Please sit back.
I have looked at it. I'm pretty sure that it is benign. I've run through the ABCD criteria, and it has none of the red flags. But I'm not 100% sure.
Dr. Johnson, do me a favor. Please see if there are any other patients waiting for us. I'll be with you in a few minutes.
Sure, okay.
You can sit up now. Well, I believe Dr. Johnson was correct in his assessment. I, too, believe it's not cancer. I don't think there's any reason for concern. We'll monitor the mole to see if it changes. I don't think it will, though.
Thank you.
Can you help me understand what was happening between you and Ms. Long?
I don't know what you're talking about.
To an observer, the way you smiled at each other, I wasn't sure if the two of you were flirting or what. And putting your hand on her shoulder while examining her breast could easily be misinterpreted. And finally, exposing more of the breast than is necessary to perform the appropriate exam is simply improper.
But I never meant anything by that. I meant only to be supportive. We're always being told that establishing a supportive relationship is good for the patient.
I think I understand your confusion. But you need to be careful how you provide reassurance so that your intentions are not misunderstood. What happened in that exam room, that should not happen. I accept that your intentions were professional, but your behavior was inappropriate despite the intent. You need to remember that patients can interpret your behavior not always the way you intend it to be. Think about it, and don't let it happen again.
I see your point. It never occurred to me. Thanks, doctor.
Oh, and by the way, I agree with your diagnosis. The mole looks benign.
We need to differentiate boundary violations from what we call boundary crossings, although even these call for caution and good judgment. Boundary crossings involve transgressions that are minor and in some ways could be seen as appropriate. They may involve attending a patient's wedding or a family funeral, putting a hand on the shoulder of a colleague in distress, or inviting a student out for lunch. These are behaviors that physicians commonly regard as displaying humaneness and caring on the part of the physician. However, it is the physician's responsibility to understand and evaluate the potential meaning of any interaction to a patient or learner. For example, touch might signal support or consolation to one person, but for another, it might constitute an acknowledgement of intimacy. Because of the potential variability of interpretation, it is critical that the physician refrain from any behavior that might be interpreted as provocative and/or likely to cause confusion. Nonverbal communication is heavily influenced by cultural differences. For example, the experience of body or personal space and its invasion varies greatly. Sitting in close proximity may be experienced by a person from one culture as friendly, but by another as threatening. Eye contact is another area of difference. In some cultures, direct eye contact is considered impolite or aggressive, so it is avoided. Other cultures regard it as an expression of openness and honesty. Smiling and nodding may mean agreement, understanding, and assent, or it may only indicate respect. Touch must be carefully considered because physical contact can convey a variety of different meanings. Because of the growing cultural diversity in the U.S. population, it is increasingly likely that physicians and other members of the healthcare team may differ in cultural backgrounds. The physician who is knowledgeable about cultural differences and who therefore can avoid potential pitfalls is wise indeed. The effects of boundary violations on patients can be severe. We must remember that patients come to physicians for help and healing. Their trust in the professional relationship is what allows them to engage in the very personal nature of a healthy doctor-patient relationship. When that relationship is distorted, when it becomes an inappropriate personal relationship, the patient may sustain very real psychological damage. Depression, anxiety, and sexual dysfunction can all result. Those who are not able to cope with the unhealthy relationship or its loss may even turn to substance abuse. Consequently, patients may refuse to seek treatment for fear of being victimized once again. Many of these same consequences afflict trainees if more senior physicians violate the boundaries an educator needs to maintain with a learner. Given these facts, it would be better for all physicians to avoid what Simon lists as the physician equivalent to the slippery slope, starting with a slow decline in physician neutrality and ending in a sexual relationship. It is essential to communicate and model appropriate behavior for residents, to observe their behavior in order to monitor for potential boundary violations, and to have clear policies for these situations. Finally, the importance of role modeling cannot be overemphasized. Faculty members need to be everything your residents are expected to be. Professional boundaries are often imprecise in their nature. Unless we are talking about the blatant violations of standards usually only perpetrated by sexual predators, actually relatively rare occurrences, appropriate behavior is not always black and white. This can pose problems for the inexperienced physician in training. Beyond acquiring additional knowledge about dermatology, clearly there is an opportunity for our resident here to learn the difference between an empathetic relationship with a patient, one that attempts to build rapport and put the patient at ease, as compared with one that may create difficulties and lead to the slippery slope of inappropriate behavior. Let's see what opportunities there are for learning in this situation. What you just saw, however inadvertent on our residents' part, was a boundary violation. Two critical points. First, boundary violations can occur anytime there is an imbalance of power, and that imbalance can manifest in a variety of relations. In relations between doctors and patients, between attendings and residents or students, between residents and more junior residents and students, and between physicians and staff. Second, in deciding whether or not a behavior violates a boundary, the interpretation of that behavior is just as important as the intention that motivates it. Why do these points merit emphasis? Because physicians, after all, are people first. As such, they are fully capable of errors in judgment when it comes either to their patients or others over whom they may have power, or when it comes to implications of their behavior. However, because doctors are ethically bound to do no harm, the onus of any impropriety falls squarely on their shoulders. We can never, it would seem, be too correct. This segment of the LIFE program has been designed to help you understand and handle boundary violations. After working through the program, you should be able to recognize and discourage improper behavior in residents. You should also be able to intervene if it occurs and deal with it effectively.